miss that simple stuff when really you are doing a lot of work. It's just in your head at this point. A person asked a question, is establishing care sufficient for a claim if there is no chief complaint? Good question, and no. Establishing care is not a complaint. It's very frustrating because, of course, every patient who gets a new insurance, they're told, make sure you go establish care with a primary care doctor, but they need to have a complaint. So sometimes you have to stretch it a little bit, but usually everyone comes in with something wrong. They have heartburn, or they have some constipation, or you turn that establishing care visit into their annual physical if you can, if you get all that physical done in that first visit. So yeah, you do have to have an actual complaint. It's very frustrating. So that's one of the unfair pieces to this system. You should also be documenting appropriate health risk factors, i.e. are they smoking, what do they drink, what is their drinking or their alcohol intake, any other recreational drugs. Of course, the patient's progress, response to, and changes in treatment, revision of diagnoses, and then, of course, the diagnosis and treatment codes that you're going to put onto the HCFA or CMS form. So we're kind of square pegs in a round hole. We are indies. We think a little bit differently than most medical doctors. The system was not built for us. We're trying to fit into it. It's great that we're allowed into that system, but it does require us to be a little more on top of it. I think of this as always wearing two hats, or being a little bit, not that I am an anacardium, but anacardium and homeopathy, you've got the angel on one shoulder, the devil on the other. I'm always thinking I'm kind of both at the same time in every visit. Of course, I'm going to put the analogy, the devil is typically not us as naturopath. I'm going to say that's the man, that's the insurance company. But I'm thinking about the rules, I'm thinking about the guidelines, and that's kind of on one shoulder. And then I'm thinking about me as naturopath, herbalist, homeopath, counselor on the other side. I don't want to discount anything that we do as naturopaths because we do a great job with all of those things, but I have to somehow fit that into language that conventional diagnoses and management can understand. So we have a larger process on our shoulders. It's incumbent on us to be the practitioner and the translator of our medicine, so that if someone else, a nurse or a medical doctor, read our notes, they still understand what we mean and what we're doing and why it's medically necessary. Remember, that's what they're preoccupied with. So my examples here, remember, adrenal fatigue doesn't exist in their world. Adrenal insufficiency, that code, that ICD-9 code, is not adrenal fatigue. We have to know that stuff, and we have to then use a code like fatigue or stress reaction, or find some other symptom code to explain that piece. Adrenal insufficiency in their world, they're talking about Cushing's or Addison's. It's not the same. You have to chart in terms that they can understand. Use those common abbreviations. If you make up your own abbreviations, like in Phys Med, make sure you have a key at the bottom of your chart note so that anyone looking at your note can understand what's happening. Oh, this symbol means muscle spasm. This symbol means nerve pain. Whatever it may be, think about someone else looking at your chart note. Use language that a non-ND can understand, because that's who's reading our notes. And then learn the language of CPT. That's what we're doing tonight. We're confirming that language. So if you're charting in language that they use in their guidelines, then there's no way to confuse what we did in any of our visits or to argue that we didn't do something